welcome to the Hall of Famers Roundtable. I'm Sungita Kumar. I'm a stroke fellow at Columbia.
I'm Sana Aslam. I'm a movement disorders neurologist at the University of Colorado.
And today we will be having a lovely discussion with our Hall of Famers.
Yes.
Want to start us off?
Yes, I'm going to start with Dr. Birbeck.
Yes. So some of Dr. Birbeck's many titles is that she's a professor in neurology and research director of the epilepsy division at the University of Rochester School of Medicine. But for 3 decades, ish, Dr. Birbeck has conducted clinical care research in sub-Saharan Africa, primarily in Zambia, and continues to lead epilepsy care initiatives in the country's rural southern province. Her work has focused on neurological disorders in resource-limited settings, research spanning epilepsy-associated stigma, neurological morbidity, health services. We learned today about cerebral malaria, and improving outcomes for underserved and under-resourced populations. So Dr. Birbeck, you've spent half of each year based in Africa, directing the epilepsy care team in rural Zambia. A lot of your work focuses on building systems of care in resource-limited settings. What have those experiences taught you about what really makes care sustainable?
Right. So I've tried it many different ways. It doesn't work.
Yeah.
Trying to take models and approaches from high-income other settings and even adapt, and that has never worked. And what seems to work best is to try and develop something fairly novel where you're at and be willing to listen to people who on paper have lots less expertise than you do, but you know the population and you are part of the population, and letting them guide development of what needs to be prioritized and how it should be designed. And this is harder than it sounds like, because you have to relinquish a lot of the decision-making and power to other people. But if you can do that, you will see it succeed beyond your wildest hopes. And if you persist in trying to kind of cram the square peg into the round hole, because you're familiar with the square peg, you will get nowhere. Yeah. But it is not a trivial process. And it also requires a significant amount of trust on the part of people informing you, because they have to think they're listened to and that they're not wasting their time.
I think to just follow up on that is, some of the conversations that we had earlier today are about how does work that we do global health translate to American health, so to speak, from a grantsmanship perspective, funding perspective, but also I think a generalizability is always a critique from a reviewer, or just even when you build programs. Would you say it's fair that perhaps the methods of engaging community and involving community is perhaps the unifying factor, not necessarily a based may not work elsewhere?
Absolutely.
Yes.
Thank you. No question about that.
Yeah. All right. We will now go to Dr. Galvin. He is a professor of neurology and psychiatry of behavioral sciences and the Alexandria and Bernard Schoeninger Endowed Chair for the Memory Disorders at the University of Miami Miller School of Medicine. He is the division chief for cognitive neurology, the founding director of the Comprehensive Center for Brain Health, director and principal investigator of the Lewy Body Dementia Research Center of Excellence, and principal investigator of the Native Alzheimer's Disease Resource Center and Minority Aging Research. Throughout his career, his work has focused on Alzheimer's disease, Lewy body dementia, healthy brain aging, and improving access to culturally relevant cognitive assessment and dementia care across diverse populations. Dr. Galvin, your research focuses on developing and validating clinical assessment scales to improve detection of cognitive impairment in multicultural community samples. What are the biggest methodological pitfalls when designing tools meant to work across cultures, and what still needs to be fixed?
That's a great question, and I think what was brought up by my colleague is that if you try to fit your square peg into a round hole, you're likely to fail. So if you have a square peg, you want to find a square hole. If you have a round peg, you want to find a round hole. And I'm using that as an analogy because I think you can't go into a community that you don't understand until you understand the community, right? So when we approach a new population that hasn't been well studied, the first thing to do is sort of engage and find out a lot about that community. And we educate that community. And by educating the community, we also get educated. And then we can figure out what tools are the most appropriate to bring into this community. And sometimes that means adapting a tool that's already there. Sometimes it means creating a new tool. And so I think if you go in there with a preset notion that I'm going to take this cognitive test that was developed in, white English-speaking adult men, and I'm going to take it into this population I never studied before, you're not likely to be successful. So the methodologic challenges are figuring out what does that community understand about the disease or process that you're talking about, and what are the risk factors associated with that community, and then how do you assess that? And then trying to get to the question of why. Like, why do some people develop disease and other people don't? They may share common risk factors. What makes some people more vulnerable and what makes people more resilient? If you don't think about those issues, you're sure to be disappointed, and you're not going to provide the communities with those things that they need.
And so if I were to go into a community tomorrow and I wanted to study, let's say, dementia or Alzheimer's disease, who would be the right person to talk to get an idea of what the community needs? Like, where should someone start to do something like that?
Well, you have to ask the community that question, right? But there are some, depending on the community, there are some natural places to go. So, for example, in an African American community, churches would be a great place to start, right? Because it's a very important part of that community. So you try to reach out to those sort of community leaders or key opinion leaders and get them involved. And you can get like a top-down kind of filtering. But you also have to talk to members of the community, and you get that grassroots, bottom-up kind of thing. And where they meet, that's where the sweet spot is, that you can make sure that, one, you're going to provide something that's going to be useful to them, and two, that information you gain can be acted on.
That's very insightful. Thank you.
If I may add on to that question, we talked a little bit earlier about how we've, in some ways, not made much gains in addressing disparities in stroke and epilepsy and just brain health in general. And when we talk about engaging community and building relationships, repairing relationships in communities, and then building interventions, and then understanding that particular community, I guess what I'm trying to get at is how do we bridge that, being individualized for one community, investing in there, to policy that is going to be, much larger scale, and it not taking decades and decades, and yet no progress is made as from an intervention standpoint.
Yeah, well, the beginning of every epic journey is the first step, right? And so until you engage a community, it's really hard to know what those factors are. But for policy to work, it has to benefit the people that policy is written for. And so, there's a lot of legwork that goes into that. So I'm not involved so much on the public policy side. What I want to do is provide the useful pieces of actionable information that a policy then could be developed around.
All right, Dr. Howard is a professor of biostatistics of the University of Alabama at Birmingham School of Public Health. He is one of the founding leaders of the landmark REGARD study, which is the reasons for geographic and racial differences in stroke. His work has fundamentally changed our understanding of why stroke disproportionately affects Black Americans and people living in the southern United States. He's helped redefine the national conversation around stroke disparities and prevention. Dr. Howard, the REGARD study has become a cornerstone of our understanding of racial and regional stroke disparities. If you could, I know somebody said they didn't like this question, but if you could implement one large-scale public health change tomorrow, you were emperor of the world, yes, to reduce stroke burden, what would it be?
Well, I think that there are two questions. One is reducing stroke, and a completely separate question is reducing stroke disparities.
Yeah, fair.
Because I think we've been phenomenally successful in reducing the burden of stroke. Just in the last 60 years, it's dropped by 75%. While that's been going on, we've been failing miserably at reducing disparities in stroke. And I think that's because we've been directing our question. We've been asking a slightly incorrect question, and I think we need to back up and reflect on why we've been failing. We've been asking the question, what can we do to lower the stroke burden in African Americans? And instead, I think we ought to be asking what will differentially reduce the burden of stroke in African Americans, which is a completely different question. And the example I'll give you is, for example, perhaps, don't know this, and I think this is where the research needs to be guided to inform good interventions. It could be that reducing salt in the diet will have a larger burden, a reduction in stroke risk in the African American community than the white community, because potentially African Americans are more salt sensitive. They have a little bit of salt in the African American community might be more harmful than a little bit of salt in the white community. And so therefore, I think the holy grail to reduce the disparities, my current thinking, is to reduce the disparity in the prevalence of hypertension between the black population and the white population. And perhaps the way to do that is to change things like the salt intake. Having said that, that's very, very hard. Just getting people to change their diet is a huge mountain to move. But there are other ways that we might do that. For example, in England, they've removed a lot of the salt out of the diet through policy changes. They basically, the main place we get salt is in processed food. They've taken about half the salt out of the processed food in the UK. And if we could do something like that, I think that is something that is targeted not at reducing the burden of stroke in blacks, but to differentially reduce the burden of stroke in blacks.
Why do you think, or rather, we've talked about, or often it comes up about how you code switch what you want to do to get what you need. So, for example, for a policymaker, you may present data in a different way, or from an economic perspective versus a moral imperative for a young medical student of researching something. What do you have a sense of what was different about the conversation in, say, Britain, where they were able to implement this, big food?
It's a huge deal because the food companies, salt is good to have in the food for preservatives and makes its shelf life and a lot. So there are a lot of forces. And in addition, it's a very acquired taste. And so making changes is challenging the sale of food. And so you have to be clever in how to do it. And I think they were extraordinarily thoughtful. They basically backed off of the salt itsy bit every year. And so very few people even noticed. I'm not sure America has the infrastructure right now to be thinking of policy changes in public health, or the people leading that might be seeing things differently than scientists.
Well said. I actually had a follow-up question too. If you were to design another large-scale study,
In other regards,
are there any additional risk factors that you'd like to look at? Sounds like the salt intake was a big one. Is there anything else that you think we should be looking at?
Well, we're lucky in regard. Regards also has 140 funded ancillary studies, and they cover the range of things as broad as people's imagination. The crazy things. Dr. Leslie McClure at St. Louis University has a ancillary study looking at air pollution at the participants' homes measured from satellites and how that's related to stroke risk. And my research partner, Virginia Howard, has a strong interest in childhood exposures, and so she's gone back and for every participant found what grade they were when they were in the sixth grade, how many school days there were in the schools in their sixth grade experience, and how much money is spent on black education and white education, which unfortunately in the past was saying it's different would be the understatement of the day. I mean, it was the average white school year was 180 school days. The average African American school year was 120-ish school days. And so, I mean, there were fundamental differences. And so I'm not sure a new cohort's the best thing. I think we could work on what other measures could be added to existing cohort. In regards, we're just getting ready to recruit another 12,000 participants to look at temporal changes and, what baby boomers versus Gen X, basically. what are the differences when you were 45 back then versus 45 now?
Well, that
And so I think a lot of crazy things, I think what limits science is your imagination.
I like that. If I may then plug something you said earlier, if any listeners are interested in studying or doing small studies or looking, just analyzing regards data, then they may reach out to.
Well, actually,
Or write a paper.
We'll write a paper or ancillary studies. We absolutely, one of the things in regards we're most proud of is a little bit over 80% of the papers in regards are first authored by people who are not part of the research team.
Oh, that's great.
And we're just past 900 papers. And so it's an exercise that's really driven home the more you give away, the more you get to keep. And generosity is an evil, manipulative, positive force. But it's worked out very, very well. The easiest way, if anybody would like to do it, is regards.org on the email. It has the forms you need to. It is a bureaucracy. Regards is a bureaucracy. We try to have it be a friendly, warm bureaucracy, but there are forms to fill out and things to do. We will either, if you want to write a paper, we will do the data analysis for you for free. Don't ask for a second paper until you submit your first paper. That has the disadvantage of you have to get in a queue. I mean, it is a bureaucracy. Or we'll provide you a data set, and you can do your own analysis. We do ask to review papers before they're submitted, mainly to make sure that that you haven't done something that will embarrass the study. I don't know how to say that politely, but basically that you haven't done something.
Well, you've done an appropriate analysis and well mentored.
Yes, well mentored, and we welcome that, and also for ancillary studies. And the other reason for the paperwork is to make sure two people aren't writing the same paper or submitting the same grant. But people tell us that we're easy to work with, and I hope we are.
Thank you. Good plug.
Okay, next we have Dr. Trevathan. He is the Amos Christie Chair in Global Health and Professor of Pediatrics and Neurology at the Vanderbilt Institute for Global Health. He is a pediatric neurologist and epidemiologist. He has spent decades leading research and public health initiatives focused on childhood neurologic disorders, epilepsy, and global health systems, particularly throughout sub-Saharan Africa. His work has included NIH-funded projects addressing epilepsy treatment gaps, neuroepidemiology, and workforce development in countries including Nigeria, Uganda, and South Africa. He also previously worked at the CDC. Your career has moved fluidly between clinical neurology and CDC leadership, academic roles, committees such as the NINDS, and global health research. How do you think about the role of each of these sectors plays in advancing equity for children with neurologic disorders, and which lever do you think is most underused?
Well, it's a good question. I guess the first thing I might correct is the word fluidly. I went over this question, or similar question with my wife recently. She wanted to emphasize that it's not that smooth. But we have different cultures. If you look at the neuroscience culture and the public health culture, clinical work, people that do public policy, they're different cultures. I think one of the things that we sometimes miss is that at a very fundamental level, people tend to get into all these fields because they want to do good things for humanity. And so I think calling on people's core self, their best self, reminding people, why did you go into health policy, or why did you go into neurology? To begin with, helps people come back to a common area where they can have conversation. And I think that's really where we really sometimes don't make achievements. We don't see common ground. I think the lever that we don't pull near enough is exactly the lever that Dr. Howard just mentioned. It's big scale public policy. and sometimes it requires a political engagement and engaging communities of affected people, as Dr. Young discussed, that we just don't think of. So many of us are, for example, very well, we are aware of folic acid fortification of flour, which has significantly reduced the burden of neural tube defects, and also congenital heart disease, which a lot of people don't know has prevented congenital heart disease, probably reduced some neuronal migration disorders in the brain, although that's difficult to measure, through this type
And
of...
lowered homocysteine.
Lowered homocysteine, reduced the rate of stroke, eliminated folic acid anemia deficiency, folate deficiency anemia in the population. But to get that done took some pretty vigorous politics. In fact, a story that's missing often is that the Senate had an issue on this matter that they let sit for months and months and months. And they didn't vote on it until, I'll use his name since he's recently died, one of my former mentors, until Godfrey Oakley and some people unofficially championing this issue got a large group of people with neural tube defects in wheelchairs, and they blocked the Senate parking lot.
Wow.
Until the Senate you said that they would agree to vote on this issue. And, those sorts of things are not really what falls into the area of comfort for those of us who are in neurology. But partnering with communities and having great relationships, as has already been said, with the community of people that our work impacts, I think is also a lever we pull near enough.
Yeah, that's a very powerful image you described. Your lecture today focused on posing global health as a security risk. So a lot of things we talked about today about disparities and dementia and stroke, how would you suggest that we could pose that today as what would be your message, let's say, to Congress today? And how would you frame it as a national help or as
Right.
global?
Well, I would say I'm not ready to propose it to
Sorry,
Congress.
put you on the spot.
You can workshop
Sorry to
it.
go back. I think there's a lot of work that needs to be done with the community affected, having a lot of community engagement, people who are at risk for brain health problems, people who have had stroke, and I think people with epilepsy. We need to bring in the different players, health policy experts, people who are leaders and ministers of health, global health leaders, scientists, politicians, local politicians. And there needs to be a discussion for us to come together with language that we all understand and agree on. That's something that realistically takes years. But I do think that we're at a point where we really need to do that. But we don't have to use our imagination really much to understand that a community that has lower rates of risk factors for stroke is a community or a nation that's better able to defend itself. A community that has lower rates of dementia and stroke and cognitive decline that occurs, as we heard today, before stroke, they're in a better position, their leaders are in a better position to make better decisions for their people, and their workforce can be more productive, so their economy's better. So I think once we all start having the discussion around those areas, the common language that can be effective for policy can come out of that.
Out of curiosity, and perhaps you don't know this off the top of your head, how long did it take from it's well accepted within the scientific literature that folate is important for preventing neural tube defects to this is just accepted it's in our food?
I could pretty much tell you that because I witnessed it.
There you go.
But I think that it was in the late 80s. I could give you a date. Godfrey Oakley wrote it down on a napkin at a meeting in 1986, I think he said. And I heard about it in 1987. Big clinical trial was done. Thousands of people women in each arm. Done through U.S. and China collaboration. And it was the US CDC and the China similar organization that was also named the China CDC that actually brought that study together. That was then finally published in the late 90s. And then from the late 90s, it took several years after that, after the data were firmly established in clinical trials, it then took another many years, depending on what goal you're talking about. It took anywhere from 5 to 10 years to get things really rolled out so we had folic acid fortification of grains, and then many more years until it actually got into corn masa flour that really benefited the Latin American community. So all total, it was probably close to 20 years.
I think sometimes we forget that when we have these conversations about how things have gotten worse, that perhaps something to remember is how long some of this takes from talking to community and just, getting square peg for the square community, and then it becoming just something that, a generation grows up with as fact. Can take a long time, and so perhaps it's not always doom and gloom.
Yeah, maybe in 20 years we'll
Maybe
have
20 years.
I'd like to see us move faster.
It'd be nice. There would be
Maybe
one
not
house
the
that's,
status of the drinking water, salt and
Judy the Salt, right? All right, and last but not least, we have Dr. Yaffe, who's the Scola Endowed Chair, the Epstein Endowed Chair, and Vice Chair, Distinguished Professor of Psychiatry, Neurology, and Epidemiology, and Director of the Center for Population Brain Health at UCSF. She's an internationally recognized expert in the epidemiology of Alzheimer's disease and related dementias. Her research has been foundational in identifying modifiable risk factors for dementia, showing that a substantial portion of risk may be preventable. She leads major longitudinal studies aimed at translating these findings into strategies to reduce cognitive decline across different populations. Dr. Yaffe, you and your colleagues were among the first to show that potentially 30 to 40% of dementia risk is preventable. How does that finding change the conversation in the dementia field, and what has been the hardest part of translating that evidence into clinical practice, especially for underserved communities?
Well, the field's come a long way. Yes and no. It's come a long way in some ways it hasn't. I think this idea that we can do something about reducing risk of dementia is very hopeful. And so that's exciting. And we see actually there's some temporal trends if you compare what was happening in the 90s, say, to what's happening in 2010, that there actually have been some shifts lowering the incidence of dementia. That's, again, against what we know, which is people are living older and the demographic shifts in terms of the baby boomers. So there will be more dementia per se, but we think that the actual rate has gone down slightly because probably of attention to some of these risk factors such as vascular disease, improving blood pressure control, use of statins for lipids. So I think it's a message of hope. In this country, we're very driven by technology and pharma and big tech, and so it hasn't caught on quite as much in this country, I'd say, although it's gained quite some momentum. In low middle income countries, people are really jumping on this because they don't have the resources for these very expensive new Alzheimer's drugs or PET scans, but they recognize that their populations are growing older. Dementia was never an issue before, but now it's a big issue. In fact, it's going to quadruple, triple, quadruple, depending on the region. So I think a lot of countries now are embracing this concept. And I was privileged to attend the G8 summit a while ago in London, and there was a big focus on dementia. After that time, now it's G7, but after that time, many countries around the world developed a national dementia program or plan, and are now really trying to roll out some of these risk reduction strategies. So I think it's an exciting time. I would like us in the U.S. to see a bit more of this on the policy level. Again, hard to do. I've worked a bit with the CDC at trying to roll out some of these at a statewide level. But I'd like to see dementia be treated more like cardiovascular disease, which is you have drugs, but you also do risk reduction. They shouldn't be one or the other, but we live in a bit of a polarized world in the U.S. And so that's my hope, that we'll come together and do both of these things.
Sometimes I think what's highlighted a little bit at this conference here is how well perhaps the stroke world has been aware of disparities. And perhaps some of that is just the acuity of the disease and the ability to study it. But then I'm in movement disorders, and so the neurodegenerative world, I think, has looked at this a little bit differently. Do you feel like there are lessons to be learned from how acute disorders or diseases like stroke are studied, and how we kind of learn about disparities and how we plan to address them that can translate to neurodegenerative disease?
Absolutely, and I'm really enjoying all of you in this conference because I'm in my little bubble and I don't hear about epilepsy or stroke a little bit, but not as much. And so I think we can learn a lot about just these disparities across clinical neuroscience conditions. And I do think we need to, you're right, the field has lagged a bit, I'd say. So yeah, I think we can learn a lot and learn from one another.
I'm enjoying Lou. If it's not out of order from
Please.
Gage, you can slap me down. But no, it's fascinating. I guess I have a two-part question. How do you know, or how is the prevalent incidence of dementia tracked? Is that hospital records? And it's interesting because stroke has been going down pretty consistently since 1900, 900. I mean, it is just straight down until the last 6 years where it's beginning to go back up. And I do think that these are brother-sister diseases. And I was wondering, how do you know it's been going down, and have you looked recently to see if it's beginning to turn to go? The obesity epidemic is probably driving a diabetes epidemic and a hypertension and so the risk factors are beginning to go back up also.
Yeah, so the studies I alluded to, which showed the temporal trend change, they're mostly cohort studies where they have been going on for a number of years, like regards. Number of studies in Europe and in the US where they did a dementia assessment incidence and then 20, 30 years later did it again. So we don't have going back to the 1900s. I don't think, at that point people thought dementia was normal aging anyway. But I agree with you. I think if we were to do another point in time in the next 10 years, we will see an uptick because of the obesity epidemic and the rise of diabetes, et cetera.
Do you think it's an uptake, or do you think it's an awareness of diagnosis?
I think
And making into EHRs.
in this case, it's complete 100%. It's difference in risk factors because it was the same case ascertainment in the cohort. It's a cohort study. So people did it the exact same way, separated by 20, 25 years. And so I'm sure it's not a diagnostic issue.
And if you want to really study disparities, then look at electronic health records.
Right.
Because what's charted in a white
Yes.
individual's chart is very different than what's charted in a non-white
Yeah.
chart.
Yeah.
And in fact, when you use EHR, like we did with the VA data, you're probably not getting the full picture because of the diagnosis is less.
Limited by the ICD codes when that's on.
Or by the access and the level of the workup. So,
Which is really my question about, was it medical records?
Yeah.
If it's going down in medical records, that's even, frankly, more amazing.
Yeah.
No.
Yeah. And it's interesting because we looked at just ICD codes for Parkinson's disease, for example, and then just markers that might suggest severity and like medications are so, and it's so different and what makes it to the EHR and where and how and which sort of community, which zip code. And so EHR is interesting. Because especially large EHR studies or studies at large academic centers, I think most academic centers have the challenge of not, there is a group of people that make it to tertiary centers or academic centers, and you've left a significant portion of the community out. And so, I think databases or registries that are specifically designed to recruit everyone are different than perhaps EHR because of just a selection bias, perhaps. But do you think there's still value in that data?
That's why I like the VA
Yeah.
national data, by the way, because everybody is in that
Yeah, it
from
doesn't
all over. So it's,
yeah, I think there's value in it, but you have to know the source of your data, right? So if you're looking at your health system's EHR, then you may be limited by what the referral patterns are for tertiary health system. If you're looking at a data lake of EHR data, like a national database of EHR data, then you're drawing it from all over the place, right? And so, you get rid of some of those inherent biases. So I worked on a paper with a pharmaceutical company where we pulled data from the Optum database, and we looked at how dementia diagnoses were charted. And it was 200,000 records we looked at, and if you had Medicaid, if you were Black, or if you didn't speak English, you were much less likely to have a cognitive assessment in your chart. You were much less likely to get a diagnosis. If you had a diagnosis, you were much less likely to get treated. And so those disparities exist, right? And so if you're not getting treated, you're not getting charted the right way, you're not getting diagnosed the right way, then it's really hard to know exactly the true extent of the disparities that exist. But the disparities in the medical record, forget about health disparities, there's such disparities in the record that it makes it hard to fully understand the full extent of the problem.
Even who gets referred to a tertiary center, or even has the option to do that, or present it to them.
Yeah, so you're a movement disorder neurologist, right? And so, if you look at the racial disparities in Parkinson's disease, you would think that Black individuals don't get Parkinson's disease, but that's not true.
Yep.
Now, but why? So if we have ascertainment of Alzheimer cases where we say that African Americans and Hispanics are at a higher risk for developing Alzheimer's disease, that data is coming from the same centers that have movement disorder clinics, yet you're not seeing African Americans with Parkinson's disease, but that doesn't mean they don't get it. So I think getting to the root of why there is these disparities is almost as important, or maybe more important, than studying the disparity themselves.
I couldn't agree more. I mean, very self-serving position to take, but I'm a big advocate for cohort studies that evaluate everyone using the same protocol. And it turns out sick people go to the doctor, and well people don't go to the doctor, and so many other things like that. And to me, I think that the big data urge that's going on with America, I think we need to reflect on very carefully. And like you said, I think you need to know where you're, because I think what big data actually gets you is a very, very precise, incorrect answer. So you got it with great precision. Might be the wrong answer, but you can estimate it to a number of decimal places.
I feel like we could talk forever, but
We just leave with a last question for everyone.
I think what I would, I'd really like to know, we've talked about your work and disparities, but a little bit about your professional journeys. I feel like often highly successful folks, when they talk about their journey in profession, it feels like a very fluid process, even if it wasn't. So I guess I have a two-part question is, do your careers and how you are successful now look the way you expected it to look? And was there sort of, a moment looking back now that was very disappointing but had turned out to be exactly what you needed to do the work that you were meant to do?
I'll tack on one thing. Beth, what advice would you give to all of these early career neurologists here about starting their journey in health equity?
Well, for me, I think we're in the era of team science, and I'll start with that as an observation. And so I think my dumb luck was that I lucked into being part of a very good team when I was a very junior person. I wish I could say I carefully selected my mentors and I chose what university I went to carefully and that type. It's just, for me, it was dumb luck. But now looking back, I can see exactly how lucky I am. And my advice to young people is to find teams that work well together and try to affiliate yourself with the team that works well together. I think the most successful trait of an assistant professor is someone who can gracefully take, who can receive. And the most defining characteristic of a full professor is someone who can give.
True. Yeah.
and the successful associate, I guess, gets to do both. But I think it's that environment where junior people can take and prosper because of their taking, and the senior people are comfortable. I mean, we live in a system invented in the 11th century where you're only going to get promoted 2 times in your life. And so once you make full professor, there's no reason not to be generous and give. My personal goal now is to get demoted. So, I think finding that environment that works that way.
You said so much. Let's see. Bumps along the road and advice, right? When I see myself, I think I always knew I wanted to do research and ask questions and try and help people along the way. So that didn't change too much. I was a psychology and biology major in college, the first person to actually try and do those, psychobiology. And so I sort of stuck with my interests along the way, for sure. But I think for me, I never really, because I was doing something a little different at a time at a university when there wasn't much going on, I didn't really have great mentors, so I had to seek them out from different places. And I would say that one of my advice to young people is really be very thoughtful about your mentor, and it's just not one mentor, it's a team. That you need to have a team of mentors, and that you can have people from different areas, maybe somebody in your department who knows the politics, somebody from a new area that you want to go in. Or I think that concept of a team. And I have a colleague who said to me once, and it's an interesting statement. He said the best prognostic factor for a candidate is who they chose for their mentor. And I thought, well, that's I guess that's true, but it's a little circular. So, but anyways, I think the mentor and mentoring team is really, really important.
Yeah, I mean, I think a lot of what I would say has already been said, but I'm exactly where I want to be, and I've always been exactly where I want to be, because if I'm not where I need to be, then I go to where I want to be so that I'm there. And so, unlike some people who have stayed in institutions for a long time, I moved quite a bit because, the situation was not where I thought it was supporting me in a way that I felt I needed to be supported. So I would seek out that. And so sometimes that's finding a new mentor. Sometimes that's finding a new environment. Sometimes it's finding a new opportunity. But for me, I think, one of the lessons I try to teach to my junior, mentees is, you have to get a mentor, right? But it has to be right for you, right? So the mentor may have an idea, this is what you need to do, but is that right for you? And if it's not, then first have a discussion with that mentor. But if you can't come to some agreement, then you need to seek out another opportunity, right? And there's a lot of opportunities out there. So again, I'm exactly where I want to be, because these things to me are not just professional activities, they're personal battles, right? And so I need to be in a place where I can fight that personal battle and build a team around me that will fight that battle with me. I don't want to fight my team, right? I don't want to fight my mentors. I want to fight the problem that we're trying to solve. And so, when one door closes, another door opens. And so I think that, there's lots of opportunities. And in the shifting funding environments, I think someone has to be fluid to deal with those different opportunities. And you just never know when those are going to come.
Yeah, so I think the point that you need to know where you want to be is critical. And I think sometimes you think we know that. For myself, I always knew I wanted to do academic neurology. Always. I knew I wanted to be a physician. In my very first neurobiology class, I was sold. And so that was my goal. But I think the fluidity comes to be important because I went a different path, my 30-some-odd years ago, to do neurology and then do the Robert Wood Johnson Health Services Research Fellowship. I think I was the second Barbara Vickery before me. at the same time, I was also pursuing my global health interests. And speaking of mentors that well-intended might be leading you astray, I was finishing my first RWJ year, and I went to the AAM, and one of my mentors from my residency said, let's get together and catch up. Great. And I walk into a hijack. There were 4 faculty members from my residency training, and this was an intervention because this was not a path to academic neurology. What I was doing wasn't going to be a sustainable career. And this, health services work, health equity, global stuff, come back home and do a real fellowship. That's a quote. So you can be an academic neurologist. And I was very angry. And I took it away, and I spent a long time thinking about it. And what I realized is, if being an academic neurology meant I had to give these things up, then actually I didn't want to be an academic neurologist if I had to make that choice. And so knowing what you want and then being willing to re-examine that pretty frequently, obviously it did work. But I think what I realized then is I don't want to just be an academic neurology. I want to do this. And if I can't do this in academic neurology, then that's actually not my goal. But you have to be clear about what your goal is, or you can't be there. And that level of sort of self-examination doesn't necessarily get encouraged a lot. And we often find ourselves kind of being pointed down kind of well-hewed paths that are really clear. And I think really examining whether that path is the right path for you, maybe you need to go off, somewhere different. There are risks today. I think we're all more aware than ever of the funding challenges, whether it's disparities work or DEI or global. But for the junior people who are thinking about this, following your passion is really your only insurance against burnout and moral injury. And that's really what's taking people out of medicine, is burnout and moral injury. But if you could pursue your passion, you have a huge cushion between yourself and those two kind of professional deaths. So I think that's just a critical thing to think about in the present environment.
Thank you.
Well, this is a tough group to follow. I just echo what everybody said. There's a lot of emphasis put on mentors, which I think is correct. And it I think properly puts pressure on those of us who are mentors to take it seriously. I think, though, that I encourage young people young in their careers, to realize that their mentors don't have all the answers. If we did, then you would have nothing to do. And so I think that respecting mentors, listening to them, having mentors in different fields is critical. And I think it's important for a few reasons. One, George has already emphasized, is that there is no such thing as really the individual investigator, individual physician going off into a room or a laboratory and coming up with some brilliant new discovery that changes the world. That's not in the cards for anybody. What this is all about is about teams and about being able to work across different, not only different fields, but different cultures. And so you have to have mentors from different fields and different cultures. And realize that some of what you're going to end up doing is something your mentors had not yet envisioned. I hadn't heard the story from Dr. Birbeck about her, as we say down south, come to Jesus meeting, you're going the wrong direction. But I had the same sort of experience because I started out as an epidemiologist and then decided, I'm in love with neurology. And I was told, you can't do that. You have to do infectious diseases, or you have to do cancer. Real epidemiologists can't do neurology. And I just was stubborn and said, I'll show you, which was maybe just my own weakness at the time. But I think you have to be able to envision something that perhaps your mentors haven't. I think the other thing that, again, others have touched on, I just want to put a fine point on it, which is at the end of the day, all of what we talk about, all of what we do, all we accomplish, it's all about the relationships. you have got to have good relationships with your team. You have to have a team that's made up of people that values relationships, because it can take years to develop great collaborative relationships, great relationships with the communities that you're serving that at the end of the day have the answers, they just haven't told you yet. And yet it can take just a brief moment to ruin a relationship and sabotage a lot of work. So I've just found that all along the way, no matter what, do not burn bridges. Be strong, but don't burn the bridge, and also make sure that the relationships are solid.
So what you're saying is we don't need to build walls, we need to build bridges.
Absolutely. And build bridges over the walls.
I'll put the title for this episode.
Building bridges. I think this is an amazing way to wrap up our session today. Thank you all so much. I'm sure all the listeners feel as enriched and invigorated for health equity as we do right now. So thank you all for your time.
Thank you.
Thank you.
You both did a great job.
Thank you.